This conference will now be recorded.
So we do record the conference, the meeting, for a couple of reasons. One is because some people like to listen to it again afterwards, and the other is because there are quite a few people who like to listen to these calls and cannot join us. So we get anywhere between about 20 to 40 people a week that regularly will listen to the call. If anybody doesn't want to be identified, just let us know. We will figure out a way to accommodate you. We have one new gent, and we have a lot of people who are not new. So great to see a good turnout, especially on Labor Day. Jeff, what we usually ask people to do, if they're new, if they want to, is to tell us a little bit about their situation, how they found us, their age, their disease diagnostics, where they're being treated, where they are in their journey, and if they have any questions for us. And if you're comfortable in doing that, we would ask you to move forward. And if you're not, just tell us.
I'm comfortable.
Good.
As I said, my name's Jeff Hancock. The reason Mary's up there is that's my wife, and she actually found this for me. I had prostate surgery in February. We decided to do the surgery. My PSA was at about 5.6, and the prostate itself wasn't enlarged, so they felt like we could go in and get it all. And when he got in, it was a lot larger than he anticipated. It had grown outside of the prostate and was beginning to attach to the rectum. He got everything out, scraped where it was starting to attach to the rectum, and it took about 2 hours longer. So then, after it was all finished, the first PSA test was 0.4, but basically the doctor said, well, you know, we're going to watch that. It's almost like 0. But then the next one we did went up to 0.15, and then the third one he did went up to 0.2. So they're now suggesting that I do radiation therapy for about 8 weeks and also do hormone therapy, which I probably will do, but hesitant about it because I think apparently when I looked back on my other PSAs, my PSA's never really been high, and yet this, and I thought prostate cancer was slow growing, but it's really growing fast, or it appears that way because we don't know how fast it's growing because the PSA was so low. What we do know is that when they first did the biopsy in November, and that came back, it was an 8 and 9 as far as the Gleason score was concerned. And then, and anyway, so it's ended up being 3B plus. And so it's advanced, and I guess I need to do something, but I'm kind of wanting to hear what others have said and what this group is really talking about. So that's kind of the situation.
We got a couple of quick questions. How old are you, Jeff?
71.
71. Mm-hmm. And where do you live, and where's your treatment been?
I live in Greenwood, Indiana. Right now, the treatment is scheduled at Indiana Urology Integrated Cancer Center, which is over on County Line Road, about 15 minutes from me.
Mm-hmm. Mm-hmm. Well, a couple of things just to give you some perspective. Everybody makes different amounts of PSA. Mm-hmm. So the fact that you didn't have a high PSA isn't, well, it is significant, but it's not significant in a positive way for you.
Right.
It's significant in a negative way in the sense that men who make low PSA and have a Gleason 4+4 or a Gleason 4+5 it usually signifies difficult disease. It makes it harder to treat. So in a sense, it's not surprising to me at all that, that there was extracapsular extension, and that the disease had progressed somewhat, given that you had a Gleason 9 and you had a low PSA. That said, there is no reason why the follow-up treatment that you're looking at right now, the salvage radiation and the hormone therapy, couldn't be successful. There's a lot of controversy right now, based on a couple of recent papers about when to step in with that radiation therapy. I mean, in the past, they always said the earlier the better. But there have been a couple of recent papers that say, maybe it's worth waiting 6 to 8 months before we start the salvage, the adjuvant therapy. This would be really adjuvant in your case, because it's so soon afterwards. I'll be honest, I don't understand it. There may be some guys on this call who understand that better, but it is that is where the literature stands. So if you went to a center of excellence right now, they might be saying, well, you know, let's get you onto the hormone therapy. As far as the hormone therapy is concerned, and the guys will talk to you about this at length, you're probably facing at least 18 months of hormone therapy, anywhere from 18 to 30 months of hormone therapy.
Well, I've been kind of hesitant to do it, so the doctor's going to do it for 6 months, not 18 months.
Well,
see how it works.
Let me just say, we can't give you medical advice, but if it were me, I wouldn't be doing it for 6 months. I'd be doing it for 18, because when I've seen guys with your type of disease go off early, they finish up doing chemotherapy after another couple of years. You've got to nail this disease, and your disease is serious enough that the issues around the hormone therapy, we can help you manage. But they're going to be much easier for you to manage than this disease coming back a year from now. Now is your shot, in my view. If it, well, it was me. I mean, I had Gleason 4+4 T3A disease, and I did hormone therapy for 30 months, 38 months. And, you know, knock on wood, it hasn't come back, and that was over 10 years ago. That was 12 years ago. Now, I've got friends who were diagnosed right around the same time as me who did their hormone therapy for 6 months or 8 months, and they couldn't tolerate it, and they came off, and they've got metastatic disease, and they've done chemotherapy, and they're managing their disease. Now, I'm not saying to you that it's a slam dunk if you do 18 months or longer, but what I am saying to you is that any good treating doctor, and certainly any good genitourinary medical oncologist, would be advising you to do more than 6 months. So your decision.
Advising that, but I did have another question. I don't know if anyone can answer it or not, but one of my concerns was, what if it's 0.2, so they really aren't sure that it's just in the prostate area. They think it is because the statistics say that, but when they did a CT scan, I had like 8 nodules on my lungs, but they said, well, that's not cancer, we don't think, because it's not big enough. And I had 3 what looked like cysts in my liver, and had one low in the back on one of the spine bones. Like, I guess I'm thinking, well, what if some of that is cancer? And because we're just going to focus on the obviously the prostate and the pelvic area.
So I'm going to throw this open. I think that's a terrific question to be throwing out to the guys, and you probably need to tie down the extent of your disease, because the extent of your disease is going to really dictate the treatment that you have right now. So who would like to? Dell, you've put a good comment in the chat window. So let's come to you first, and let's go. We'll spend about 15 to 20. Let me just check one thing. Mr. Maines, John Maines, hello. John, have you been? Your name is familiar. I think you have been with us before. Is that right?
I don't believe so. I think this is my first meeting. Jeremy
Okay,
invited me to it.
perfect. That's what I wanted to find out. So we'll spend about another 10 minutes to 15 minutes max with Jeff, and then we'll come to you. Okay?
Okay.
And there's no one else, I think, no one else is new, I don't believe. No. Okay, so Dell, would you like to kick off? And Peter Kafka says, what kind of doctor is guiding this gentleman? My guess is it's a urologist from what we were told. But who's your quarterback right now?
Right,
Mr.
right now
Hancock?
is a radiologist, oncology radiologist at the Integrated Cancer Center.
It's a radonc right now who's guiding you. Okay, there you go, Jeff, Peter. All right, Dell, what are your thoughts for Jeff?
I think the choice of surgery is a good choice, because that does take control of the.
I can't hear him.
Is my mic on? You guys can't hear me?
We can hear you, but you're a little faint.
All right, I'll pull it up.
You are not a man who is faint of heart. We know this.
All right, so I think surgery is a good choice with if your cancer is fairly contained. Again, you don't know that because I do think you probably need some more testing. Did they do a bone scan?
Yes.
And the bone scan came back negative?
Well, the only thing the bone scan showed was like a cyst, they thought it was on the disc.
Okay.
But you know, they're basically saying, well, I don't think it's anything to worry about, but you know, I worry about it. So
Yeah. So the thing about the ADT is if you do have anything that's metastatic, right now it's not controlled. And the ADT does step in there, and it really does stop, for most cases, prevents rapid advancement. And so if you see your numbers come back down, that's a good sign that it's working. And the only thing that I hope that your radiologist is suggesting is you wait a little while before. So you had it in February, so now I guess would be an appropriate time because it's been 6, 7, almost 8 months since you've had surgery. And the idea there is you really want to wait until you're fully healed from the surgery before they go in and start irradiating things, because any sort of healing that happens up to that point stops, and some of that urinary control that you have gained, you can lose it if they start irradiation too. So the idea there is to hold off on radiation until that urinary control kind of plateaus, and that's really critical. And that would be my comments about it, because I went through the same thing. My surgery was in January, and I waited until August to start radiation, only because I really wanted to make sure I had the best control. And
that makes sense.
And I can turn on my camera and say hi too.
Hi, Dell. It's always good to see you. Let's go to Peter Kafka and see what thoughts Peter has.
Okay, Jeff, northern or southern Indiana are you?
I'm in Greenwood, which is a suburb of Indianapolis.
Okay, so I'm sure Rick or some others will mention this to you. I strongly think you should be under the care of what Rick referred to as a GU, genitourinary medical oncologist, an oncologist that specializes in prostate cancer. And there are some not that far from you. Chicago might be the closest. You're kind of in between Cleveland Clinic and Chicago, but Chicago's got some good people. And I do that before I started on ADT, on androgen deprivation. And I take advantage of this time. This is a terrible time to get diagnosed because of COVID-19, but there are certain things that are wise to do with a high-grade disease. One is get your tumor tissue from your biopsy, from your prostatectomy, tested for genetic mutations at this time, because a lot of this stuff could guide what happens in the future, because this disease is going to be a management game. It's not going to be a cure game. And it's going to probably go on for a while. And you need to probably, start taking some steps that you can safely do now. That would be if it was me, that would be my advice. I've been dealing with this for 6 years, and I started with a GU Med-Onc right from the gate, and it's been helpful for me.
Okay, thank you.
Who else would, Mark Perloe, Dr. Mark, you have a couple of interesting ideas, which I think we should raise. Why don't you share?
Okay, well, my situation was I rushed off and got treatment rather than get a PET scan, and only to find out later on that there was some involvement in the seminal vesicle. I think before you can adequately treat any sort of cancer, I'm a GYN doc, but before you can treat any cancer, you have to stage it. And it's bizarre and surprising to me that we get treated before we really know the extent of the disease. So I think that PET scan is a good next step, and you have some time on that. The only approved scan is Axumin, which tends not to be as sensitive and specific as two of the other commonly available tracers. One is DCFPYL, which is big in Europe, and Columbia is doing a study with that, Columbia University. And then I went out to UCLA for a PSMA gallium-68, and there are a number of places that are doing studies. If you go to clinicaltrials.gov and look at PET scan and prostate cancer, you should be able to find a place to do that. And that will tell you if this is nothing to worry about or not. There have been people with early disease who show up with lung involvement, thyroid involvement, lymph node involvement, and you really want to know that before you take on the potential side effects from radiation therapy. I guess that would be my comments.
Yeah,
Okay.
I mean, I think that that Dr. Mark's comment on staging is probably the takeaway message for you, Jeff. You really have to know the extent of your cancer. When you added at the very end that there were some suspicious areas, we just have to tie down how suspicious those areas are, because it will affect the next step. And for the rad-onc to be charging into radiation before we really know where you are, in my view, is not smart. Len, would you like to comment?
I agree with that, Rick. Yeah, we don't know the extent of the disease. If we did, then we could advise you that salvage radiation therapy would be a good idea. But if you've got systemic disease, the salvage radiation therapy is not likely to be the right course of action. You need systemic treatment, and if in fact, again, you do have systemic disease, 6 months of ADT is, I got to tell you this, that is certainly not standard of care. Whoever told you that to accommodate your preference for not having ADT, it's just not really good advice, because with go ahead.
I was just going to say for the doctor's response, I mean, she had said I needed 2 years, and I kept talking about being hesitant to do it. She said, well, I wouldn't do it any less than 6 months, but and you could decide then whether you wanted to continue, but I would suggest you continue.
I wanted to add one thing about the PET scans. My med-onc at UCLA at their Center of Excellence said that they're seeing 22% positive PET scans in cases where they're not suspecting. Now, unfortunately, they don't have a nomogram that lets us say size of the prostate, PSA, testosterone levels, Gleason scores, genetics. We don't know who those 22% are yet, but that's a fairly significant number when we expose ourselves to potential risk. So I'd strongly recommend staging before moving ahead with treatment.
Does insurance cover some of the PSMA PET scans?
No, it's experimental. So it's going to be about $2,800. I don't know how much the one at Columbia is. I know that Emory in Atlanta has just started a RH-PSMA, and I don't know if anybody knows about that tracer, but it's supposed to be as good as the gallium PSMA.
Okay. Well, I think the IU Health Medical Center here is doing a PSMA PET scan now.
Well, you know, that raises a really interesting point. It's hard to find PSMA PET scans right now that are in trial. There's a lot around the country, but some have stopped. Some are continuing. We know about the UCLA one, where they're charging around $3,000 at this point, because Jeremy told us last week it's actually gone up, Mark. It's now $2,800 or $2,900. But Peter is in the process of doing an analysis for us. But if you've got a local one at IU, then I'd certainly be digging into that. But I think it gets back to two things. One, takeaway message: got to stage the disease because your disease isn't staged. Two, you need a genitourinary medical oncologist on your team. You got to pick a good one. Now, I don't know if there is one at IU. There's nobody that comes to mind right away. We can recommend some really good folks in Chicago, for sure. Can recommend some people at Cleveland Clinic. I'm trying to think of the area where you are, you know, or you have to head east. You can start talking to IU and ask them if they are GU med-oncs. You need a genitourinary medical oncologist, not a general medical oncologist. I doubt you're going to find one at your at Indiana Urology. They're probably going to, but I'm sure you won't. But they may refer you to a Cancer Center of America or somewhere like that, where you're more likely to find a generalist. And you know, so I think these are the two big things: get a GU med-onc, stage the disease. You've got to push. Talk to your radiation oncologist. Tell her that you want a PSMA scan, or failing that, at least an Axumin scan. Now, what we haven't talked to you about is that you need to have a certain level of PSA present in your body for these scans to really show. It's never been clear to me if that's true right after surgery or not. Where they're seeing suspicious. we know that when your PSA comes back after surgery, and we don't exactly know, and we're looking to try and figure out where the disease is, we know that we want to get, your PSA should be around 0.6 or higher to get decent results. The sweet spot is probably around between 0.85 to 1. But that may not be the case where you're already metastatic and you've just had your prostate removed. There really haven't been any studies, I don't think, around PSMA scans immediately after prostatectomies. None that I'm aware of. There may be some, but none that I'm aware of. But that's a discussion that you want to have. In the big problem is that if you go on hormone therapy right now, it's going to depress the PSA and it's going to quieten down the cancer. And you really want to know where that cancer is. So you're really in a strange place. Is there anybody here who can help us in terms of guidance when you've just had an RP and your PSA is around 0.2? Does it make sense to have a PSMA scan at that level?
I would think so. I think you're not looking for disease and trying to pick up lesions in the prostate any longer. The density put out by the metastatic area is still going to be the same, and that shouldn't be affected by surgery. If you're doing a blind scan looking to see about prostate cancer, then I would certainly agree with you. When I went, I mean, my seminal vesicles lit up like, or seminal vesicle lit up like anything with the 0.4. Most of the studies are looking at intact, and I've seen some that say it should be at least 2. I was turned down from Columbia because I was under 2. They would not enroll me in that study.
Okay, thank you.
Have we confused you enough, Jeff?
Pardon?
Have we confused you enough?
No, I think you've done a good job. I appreciate it. That's kind of what I wanted to know. So I think it was very helpful.
Okay.
Jeff, this is Herb. I just want to sum up what I've heard from everybody, which I think should be important to you. Number one, I think you need a GU medical oncologist to really take charge of this. Urologists, radiation oncologists, they have their own, it's their profit center, right? That's what they do, and that's how they make their money. So you need to have somebody who can call the shots, who's sort of sitting above them and to sort of look at the big picture. And I just looked at the IU website. They do not have GU oncology. So there are places, I'd say Chicago, Cleveland, wherever, there are places which do, and I think it'd be wise to go there. And number two, I think any GU oncologist, I think, will echo what we just said, which is, I need to find out the extent of your disease before a treatment plan. And I think we don't know, you don't know it yet, they don't know it yet. And so I would say a PSMA PET scan is almost de rigueur at your stage. When you have residual disease, you don't know where the rest might be.
Right.
And then finally, I would hope that your biopsy, they did some genetic testing.
That what? I'm sorry.
I would hope that they would do genetic testing on your tumor to see if there are mutations which are treatable by newer medications, sort of precision medicine.
Well, I don't think they did that before they took it out. They did.
Well, but but they should be able to plan to do it.
Okay.
So, Jeff, we're going to move along because we have another new gent.
Sure.
A couple of things. One, we really hope you'll come back and report to us. Two,
Yes.
we can certainly give you some names of docs in Chicago to choose from. We have a number that we really like in Chicago, both at Northwestern and at University of Chicago Hospital. Those would be the two institutions that we would be thinking of. If you would prefer to go east, we can give you names if you want to head east as well. Secondly, I don't think we have your email address. You can send it. You can either send it to me, you can put it in the chat window. I don't know if you know how to use the chat window. There's a little bubble at the top of the screen on the right-hand side. And if you click on there, you'll find all kinds of conversation that people have been having about you and your disease whilst we've been talking. So you can look at that in a minute, and you can send me, if you can send to me your email address, or you can send it to info@ancan.org, info@ancan.org. And what we'll do is put you on our list, and so you'll get a reminder before every meeting.
Okay.
So our next meeting will be next Tuesday.
Okay.
Okay.
That's
And
great.
keep coming back. We will navigate you as best as we can. But I think we're sort of setting out some direction for you right now, and ways to follow. And I will tell you, there's a bunch of men who have been down very similar paths to you who are on this call. And I think that they might have done it differently had they been talking to us from the beginning.
Right. I can see that. I appreciate it. Thank you.
Pleasure. Okay, so we're gonna move on, and John Maines, welcome. Thank you for your details. Again, I'm not sure if you were here right at the beginning when we invited Jeff to talk, but if not, just tell us a little bit about your background, your age, where you're being treated. I don't know if Poulsbo, Washington is anywhere near Mr. Anderson. Mr. Anderson, are you close to Poulsbo?
No, you know, I know exactly where it is. I'm actually going to be in Port Townsend next week, right after chemo on the 11th. My uncle is in Brennan. I know exactly where it is. I love that town, along with Squam. You know,
Right.
It's a great spot.
Okay, well, maybe you and John can get to meet up. So Ken is on our board, and he's also the lead moderator for our under 60s men. And he has a lot of experience, very, very good experience. So so tell us a little bit about yourself.
Sure. Let's see. I'm 70. I'm going to be 70 in December. I've been dealing with a high PSA since 2004. On my fourth biopsy, which was done by Dr. Shinohara at UCSF, they got two very small samples. One was 3% of the total sample, and one was 1% of the total sample. That was stage 6, Gleason score 6. I had a MRI before that, which did not show any tumor. They also did a blood test where they did a digital rectal exam and then had me pee, and then they I guess it was an experimental test, and I don't know the name of it.
So let me interrupt. I don't know that you may know we run 9, soon to be 11 prostate cancer groups each month. and I'm not certain this is the right one for you.
Well, right now I'm a Gleason 7.
Right.
My last biopsy, there was of the 3 samples that came back, each of them were more than 30%. I was scheduled last Monday for a robotic assisted prostatectomy, but that got canceled because there was a COVID outbreak at the hospital.
Right. So, what's your PSA?
PSA is 23.
Well, here's where you stand as far as we're concerned. You're very welcome to sit in here. Technically, you are high risk because you're over 20. I think you'd be doing much better in Peter Kafka's group. I don't think the active surveillance group is the best for you, but I do think that this discussion, this group here is largely for men who have either been diagnosed T3, so they're starting off with very high risk, or they have recurrent disease, or they have advanced disease, metastatic disease. And thank God you're not in any of those situations. Most of us are very familiar with, not most of us, a number of us are very familiar with Dr. Shinohara. He has peered up many of our rear ends, and he is a fantastic doctor. So
Yes.
we do know him really well, including myself, and we have a lot of respect for him. Peter Kafka, wouldn't you think that this man might do better on your call next Monday night?
Sure, or if he has immediate concerns, who was going to do, just a question, who was going to do the surgery? Was it Peter Carroll?
No, I moved up to Poulsbo, and when I had my biopsy done here, I sent the reports, etc., to Shinohara, and I've consulted with him a couple of times. He said that my
Okay.
my oncologist urologist seemed like he was on top of it, and that his plan of action was everything that he would be doing.
Okay, John, I'm going to put my email and phone number in the thing, and the next meeting we have is a week from tonight, and I'll be coordinating, I'll be moderating it, but it has a lot of guys with Gleason 7s on it, who some have done surgery, some have done radiation, some have done this and that. Anyway, that would be the ideal group to be in, and we can go from there. Yeah, you've got an interesting case, but as Rick pointed out, a lot of the guys on this call are kind of in a much more serious situation with recurrent using Gleason 9s and so forth. But I will put my phone number and email in the box, and you can contact me. But it's the same station, same number, same everything next Monday. Okay?
Next Monday.
Right.
At 5 o'clock.
Yes.
Great.
Exactly. And John's email is in the chat window, Peter, and maybe you can put him on your list for a reminder. Okay.
Okay.
All right. So what we're going to do next is run down and see who would like some time tonight. And we'll try and get around everybody. We have about an hour and a quarter. We will do our best. So let me start. Since I missed him, and I'm totally embarrassed as usual, I'll ask Jake first. Would you like some time tonight, Mr. Hannum?
No, thank you, Rick. I'm okay.
How you feeling? I haven't heard from you for a few days.
I feel lousy.
Oh, that's not good.
Yeah. I think I have some kind of chest infection, a lung infection or something.
Do you want to talk about that on here? And have you spoken to the med-onc about it?
Yeah, I mentioned it to her and she said, well, it's not bronchitis because she asked about the color of the sputum. So no antibiotic, in other words. So no, I really don't, there's not a whole lot to talk about. Thank you anyway.
Okay. When's your next break?
Well, I have my last, my 9th chemo tomorrow, Wednesday. And then I get a week off.
Oh, so you have a week off this coming week?
Well, I have a chemo this Wednesday.
Oh, okay.
And then the following Wednesday, I have a week off.
Okay, so after this Wednesday, you have a break for a few days. Okay.
Right.
Okay.
So Jake, I'll call you tomorrow when you're a little on your high with dexamethasone.
Okay. Today's Monday, right? It'll be Wednesday, Ken.
Oh, yeah, okay, I'll give you 2 days.
Okay.
Okay. All right. Len, anything for you tonight?
Nothing for me, Rick. Thank you.
Peter, anything for you tonight?
Only at the end, I have an odd question from a couple of guys I'm advocating for that just came to me last night.
Okay, we will address it.
Hey, Rick, you got to move Jeremy to the top. He's been at the bottom last couple times, and he hasn't been able to talk.
Okay, we're moving Jeremy. Jeremy, anything you'd like to talk about tonight?
Just a brief update.
Okay, we'll get you. I got a little star. I'm making a star here. So, all right. Rich Jackson. Any news on the Eastern Front?
The artillery shelling ceased. Right now, we're back to all quiet on the Eastern Front.
Okay. What's the game plan, Mr. Jackson? We don't know what the game plan is.
That's why it's all quiet. The enemy is regrouping and determining a new direction. There's been no additional contact since last week, so
okay,
there is no game plan to share.
Okay, so we're not getting any more information out of you, I can see. Actually, Len, let's ask the guys about that situation that you've got with your guy in Sarasota as well. Somebody may have some information on this call.
Was that the ADA issue, Rick?
Yeah.
Yeah, I spoke to Carl. He gave me the same advice you did. Well, Carl suggested disability lawyer.
Okay, all right. We'll throw it out very quickly. We won't spend a lot of time on it. Ken Anderson, anything for you tonight?
You know, I have a small update. You know, I'll say yes.
Thank you. Joe B, anything for you?
No, not tonight, Rick. Thanks.
Dennis C, anything for you? Mr. C.
No. He said no.
Oh, sorry. I'm having trouble seeing where everybody is on this screen. It's like Hollywood Squares here. Okay. Gao Shan, welcome back. Anything that you'd like to talk about tonight?
Yes, I have my GA68 PSMA scan set for September 21st.
We'll visit with you. I'm just checking who needs time, so we'll definitely visit with you.
Okay.
Alan, anything you'd like to talk about tonight?
No, nothing from me.
Okay. Sylvester, anything for you? Where's he gone? Oh, there he is, down at the bottom. Sylvester, you're muted and we can't even see you. Okay, I'll move. When I see you, I'll come back to you. Les, anything you'd like to talk about?
Not tonight, thank you.
Okay, when are you off? When are you off for more treatment, man?
Leaving on Monday. The treatment starts on Wednesday, next Wednesday, so it's a week.
Okay. Herb, anything you'd like to talk about tonight?
Very brief update.
Okay. Carl, anything for you tonight?
Yes, please.
Okay. John Ivory, anything you'd like to discuss?
I'm just here for your wisdom, man.
Okay. Okay, we as Chico Marx used to say, we fool you, boss. Russ Smith, anything for you, sir?
Yeah, less than 5 minutes, but just a quick one.
Okay, Larry Fish, get your stopwatch out. Jerry P.
TikTok. Nothing for me tonight, Rick.
Okay. Okay. Jerry Pelfrey, anything for you?
Well, I got to tell you, if you can see it, you know, it is prostate cancer month.
Yes.
And I got these, I got about 12 of them, and I've given them out locally to guys that are friends that have prostate cancer or have had it. And I noticed a couple of AnCan t-shirts on, and I've got one. I just didn't put it on. That's all I've got to say.
Okay. Okay.
Let's promote. Let's promote us.
Okay. Yes, everybody, get your AnCan t-shirts, because where's that Russ Smith? I noticed he had one on. There we go.
Yeah, both Russ and Peter have them on.
There you go. Be your own best advocate. There you go.
What I gotta say, that the t-shirts are very comfortable. They're very, and it's a good t-shirt. Get one.
It is. It is. I agree.
This is music to Peter's ears. We have to thank Peter Kafka and his son Jeff for designing these shirts. Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Okay. Mark Perloe, anything you'd like to bring up tonight?
No, just remind people of the conference on Friday if they want to attend.
Yeah, that was, of course, in the reminder, and the conference is on Friday. There's a bunch of good speakers, including my own doc, Mac Roach, and Nicholas Fogelsang. Is definitely worth listening to. He's a really good GU med onc from who practices out of Las Vegas. Okay, Jeremy, I've got Dell. Anything you'd like to talk about tonight?
Nope, I'm good.
Good, good. Thank you for joining us. Dennis McGuire, anything for you?
Just a quick update and a question, although unfortunately I have to leave at 15 minutes past the hour, so
Okay.
if I get to it.
All right, we will. Thank you for telling me. You will be promoted. All right, so I know who needs time. Len wrote to me a couple of days ago, and he had a situation that he reviewed with me and he's reviewed with Carl, because Carl has professional expertise, with a guy who has been on hormone therapy. It's not clear to us if he's still on hormone therapy or not, but he certainly was on it for some time, I think post-treatment. And he's having some psychological issues, as many of us have been accustomed to from being on long-term hormone therapy. And he's been a bit snitty and short and abrupt at work with some of his colleagues, and he got warned. And so he wrote to Len and he asked Len whether he has any protection via the ADA, the American Disabilities Act. You know, my response was, well, he's in systemic treatment. I don't know what the protection is, but it's no different than if he was on chemo. And so we're just and we recommended to him that he get himself a disability attorney or employment attorney, probably a disability attorney, which was Carl's recommendation. I agree with that. Does anybody have any thoughts or experience with a situation like this, where how does ADA treat you when you're actually in treatment? Any thoughts or ideas?
Well, I'll add, I was sued with an ADA suit for firing an employee who told me that she was going to kill me. And subsequently, she had, between the point of putting her on leave and actually firing her, she sent a note to my manager that she was going through a period of psychological stress. And unfortunately, that wasn't shared with me, and we fired her when we found out she had made threats, and it cost over $100,000. If someone is on a medical treatment that can have psychological effects, it's got to be documented in the record, and they have to have some statement backing that up. Once that is there, they should be totally protected. And I agree that going through an ADA lawyer is going to be the best sort of way to protect his interest.
Thank you, Mark. That's really helpful. Len, do you want to, since it's your guy down in Florida, would you like to say anything more about this?
Well, Mark, the case of the fellow who's asking the question sounds similar to yours, in that your employee didn't tell you what stress she was going through, and he hasn't told his employer either.
Yeah, the problem that I had was that she had seen a doc about the mental health issue, and she had notified my manager that that she was undergoing treatment for mental stress and wanted a leave of absence. It was after that had happened, but I was not informed. I was just informed that there was a threat, and then I fired her when I was made aware of the threat. Yeah, but I was not aware that there was a letter documenting that she had seen a mental health professional. So in my situation, she had gone before I had done an action, but I think it's very important for him to document that there is a mental health issue related to the treatment and have that on record. After the fact, I don't think he can undo a warning, but I think it certainly protect him to have on record that he's seen someone in the mental health field and discuss the issue that the medications are causing that. I'm enjoying my initial start on ADT right now, and I can understand how that could be the case.
I like the advice that Carl gave, which was that probably he should go on disability if this is an issue that is beyond his control, because obviously I don't think you can allow an employee to abuse other employees regardless of their mental health status. So it seems to me, as I think Carl suggested, you can correct me if I'm wrong, Carl, that the right thing to do would be for him to be put on disability. I don't know, how can you make an accommodation to allow someone to abuse coworkers? Then you got a lawsuit from the coworkers. But anyway, maybe we shouldn't take up too much time here, Rick.
Okay.
Okay, then I won't say.
No, go ahead, Larry.
We've been
Please.
through this kind of stuff. Someone makes a threat. You should call the police about the threat. You should report the threat to Human Resources, and Human Resources has to report it to the state, depending on the state laws. The state investigates, and you can certainly give the person a warning. You can give them a written written notice, but you shouldn't be able to, shouldn't take an abrupt step of creating or firing somebody without like some recourse to do an investigation call. So you start a police report, and if you can defend yourself if you fear for your life, but firing is like a little too abrupt in action. Usually go through a HR firing process.
Larry, how is the process affected if you actually have medical a medical reason why you're imbalanced?
Well, like Len was saying, it starts to become, can you provide reasonable accommodation?
Okay.
That's something that comes out of the investigation. It's a little above my HR pay grade.
Okay. All right. So I think, Len, we have some stuff for you to go back to this guy with, and hopefully that's been helpful. And thanks a lot, Dr. Mark, for sharing your experience, and to Larry and to Carl, of course. Gents, I put the registration again, the registration link in the chat window for PCRI this weekend. That link, if you click on it, will allow you to register right now. Jeremy, tell us a little bit about this latest MRI.
Oh, hang on, let me turn this on. Okay, here we go. The new MRI was basically consistent with the previous MRI, though it showed that the prostate volume had decreased from 52.4 to 44 grams. It's still not been reviewed by the whole team, and they're also setting up to your guy Shinohara to look at. Subsequently, I also had a conversation, I think, Len, with Dr. Jonathan Simons over at the Prostate Research Foundation. And he took a look at everything to date, the genomic tests, the blood testing, MRIs, and still believe, depending on what comes back with Foundation 1 on rereading of the biopsy, that surgery should be put off until we know what's going on, which emphasizes, again, what you talked about, complete and comprehensive staging. And again, I got to thank you guys, Rick, Peter, and Len in particular, for encouraging me to get these tests and to seek a second opinion. Otherwise, I would have had surgery about a week and a half ago already. So far, everything looks pretty good. Everything's negative, with the exception the MRI still shows things, and we're still waiting to find out the histology rereading. That's kind of where we're at.
So the new MRI still shows this possibility that you have this extracapsular extension somewhere.
Yeah.
That showed up again.
Yeah, it said, I think, I don't have it in front of me, but I think it said possible mild extracapsular extension. And I did, as you guys saw, I did reach out to UCLA. They said that I would be a PET study candidate, and it is, I think, about $2,900, so they've raised the price. And I brought that up with Dr. Simons, and he thought, look, given the fact that your genetics and the blood tests and bone scans are all negative, he didn't think it was money well spent. But
I tell you what I would probably do. I'd go up and have Shinohara do a color Doppler. I mean, he's just so good. And even though it's not the most up-to-date technology, I just trust him. Peter, what would you say? What would you say about that?
I agree. I think he's good. I mean, I've had several color Dopplers done by him, and one was a second opinion. One was done immediately after I had a color Doppler done by a doctor there who saw something suspicious in my bladder, and he fortunately works in the same office as Shinohara. So I was buckling up my pants, putting my underwear and my pants back on, and he went over to Shinohara. Shinohara came back in the room, and I hardly had time to take my pants down again. But he did a second color doppler and told me nothing to worry about. So
I have a question though, but ultimately, isn't the PSMA scan sort of the end all be all, or not necessarily?
Look,
it's pretty darn good, but this was just before PSMA came in. I've done 2 PSMA scans as well. Yeah, PSMA is pretty darn good.
look, the PSMA is very good. There's no question, right? But Shinohara is so good, even with old technology, that, you know, I'd put him up against a PSMA scan. I mean, that's just my confidence in him. And it's easier, it's cheaper, and you know, but yeah, if you can get in to do the PSMA scan, I mean, I guarantee if you said to Jonathan Simons, well, what do you think about Shinohara doing a color Doppler? He said, yeah, that'd be a good idea. I mean, he'd have a different attitude about PSMA. It's just that he is a wizard with this. He's a wizard with it. And so I'm just saying, nothing wrong with doing the PSMA scan if you want something more definitive. But if Shinohara came back and said nothing to worry about, I'd tell you to do active surveillance.
Okay.
I mean, that's how much I trust him. He upgraded me from a T1C to a T3A, and he was absolutely right. So
one caveat about the PSMA scan, Jeremy, is that most, but not all, prostate cancer cells produce PSMA. Some do not produce it. So if you do a PSMA scan and there's a prostate cancer lesion, it's not going to see it if that lesion is not producing PSMA.
Right. Right. So, you know, that there are, I mean, before men do PSMA treatment for management of the disease as opposed to scanning, they have these gallium scans to see if they're PSMA avid. Because if you're not PSMA avid, then the lutetium or the actinium doesn't work well for you. So you have to be, so some men, I can't remember do you remember the percentage, Len?
No, unfortunately I don't.
I don't either. I want to say, but I think it was fairly high, but there are quite a few men that are not PSMA avid, and so the treatment just doesn't suit them. And so, of course, if you're not PSMA avid, a PSMA scan isn't going to help you much either.
I think that, again, depends on the PSA level, that the specificity and sensitivity increase as your PSA goes up. So if you have a tumor that's not making PSA, it's going to be less likely and less sensitive to do the scan. I mean, I've seen 92% as a ballpark figure for sensitivity, but I think there's so many variables that might affect that information.
I heard about 10% of prostate tumors do not secrete PSMA.
There you go. So, you know, 8 to 10%. Go ahead, Jeremy. What's your question?
They tested me for BRCA1, 2 with prostate next and the mutations, I guess. Yeah. And I think you guys know they also tested for the CT circulating tumor cells as well.
Yeah.
Those were all negative. So
I just think
are those tests meaningless?
No, they're not meaningless. But the fact that you're negative is positive for you. And so, you know, what we're trying to do is figure out how serious is this extracapsular extension that they think they're seeing. And my money would be on Shinohara to define it.
Okay.
Anyone else before we move on? Okay. Dennis. Oh, Jesus, Dennis. I'm so sorry. I got away from me. Go ahead. Ask your
That's
question.
okay. So I did have an update late last week with my radiologist. We went over the CT scans and bone scans in greater detail. And the conclusion we came to, along with my oncologist, was that I need new systemic treatment because the cancer is active despite the radiation. There's lymph nodes outside of the pelvic girdle that are growing. They're, around 1 centimeter. There's most likely other cancer less than 1 centimeter that probably doesn't show up on the CT scan. So that's the update. The question, so I'm considering kind of the most aggressive treatment, which would be chemo. That's what I'm thinking today. I'm undecided, and I'm kind of changing every day on what to do. The question I have is, with chemo, if I were to go the cabazitaxel route, I think there's a combination therapy out there that you guys might be aware of.
What's your PSA, Dennis?
The PSA is 10.
And 30 days ago?
15.
And the decrease was because of radiation?
Yes.
Look, there's a couple of things here. Hold your thought a second, Ken. The first is that the combination therapies really are dictated by a genomic sequencing. And as I recall, what you showed, the sequencing that you did, which was back in February, really didn't show too much. I don't think, I'm not an expert at all, but I don't think any of the M4, RNF43, TETI, ANKRD11 or MGA, I don't think any of those would indicate a different type of chemo, adding carboplatin, for example, which is what we might be thinking of. The question really, if you're going to do chemo, is cabazitaxel or more docetaxel. You didn't do well on docetaxel. Cabazitaxel may be a really good drug for you, and that's what I'd be digging. That's what I'd be digging down with Dr. Who is it? Who's your
Lang.
Lang? Dr.
Yep,
Lang.
Dr. Lang. Yeah.
Now, the only thing that's bugging me is that, they never, and we talked about this last time, and I want to throw this out, get the other guy's opinion. They never radiated your pelvic girdle. We don't know for sure that it's systemic because there's nothing beyond the pelvic girdle right now that's showing up. And there is this abscopal effect that we talk about that could benefit you, that could stimulate your immune system. So I'm not convinced. If it were me, I would not be convinced that not doing the radiation to your pelvic girdle isn't systemic. That's a lot of double negatives. In other words, I might want to try the radiation to my pelvic girdle on the basis that it could be systemic because it could generate an abscopal effect. And if it doesn't, then I would be jumping in with chemo. And it may be a good time to jump in the old car and take a little drive down and have a quick word with Alicia Morgans and see what she's got to say. See whether she thinks, get a second opinion. This could be a good time to get a second opinion before you plunge in. Anyway, that's my thoughts. Who else wants to jump in here?
Rick, unless I'm mistaken, I thought Dennis did say that they found some lymph nodes outside of the pelvic region. Is that right, Dennis?
Well, yeah, they said there's one in the deep abdomen which they could not radiate. And then they said there's one very close to the rectum. Now, that I'm not sure if that's considered pelvic or not.
Well, it's something that would have been covered, might have well been covered with comprehensive radiation, but the deep abdomen one got away from me. So thank you for mentioning that, Len. Peter isn't there right now. He's stepped away. Peter's had issues with deep abdomen radiation, with deep abdomen lymph nodes that he has had radiated, abdominal lymph nodes that he has had radiated. Oh, here he comes. Are you there, Peter?
Sorry.
How deep were those abdominal lymph nodes of yours that they radiated?
One was in a precarious place over by my intestines, and that's why I went with proton beam, because it was in a tricky place, and I just didn't want to take a chance. They were pretty deep. They weren't on the surface.
So that could be an option, and I think Northwestern does have proton beam.
We love Alicia Morgans, and I mean, she's so in the moment, and she's so compassionate. And I mean, I think especially with younger men, she really relates. John Ivory, what would you say? She's your doc.
She's great. She's been really compassionate. She knows all her research studies and clinical trials, and she takes as long as I need with her. And her staff is great too, her assistants and her nurses as well.
Okay, that sounds great. Rick, I think I'm going to take you up on that. Can I give you a call later this week?
Sure, absolutely. And reach out to her, and for goodness sake, tell her that we're sending you to her, because it does carry a little bit of weight. Okay. I mean, she knows exactly who we are. Obviously, she's worked with us, and we love her. I mean, she's the best. We love her.
Okay. All right. Okay. Thanks, Rick, for putting me at the top of the list. Appreciate it.
It's a pleasure. Yeah, and just follow up with me when you can, and I'll put you in touch with John Ivory if you need to as well.
Okay. Thank you.
And I also did proton with Northwestern. It was before they bought them, but if you want any thoughts about that, if you are thinking about that, let me know.
Great. Yeah, I'll connect you guys for sure. I'm making a note on here to connect John Ivory and Dennis M. Okay. It'll be done. I got people coming over as soon as I get done, so it may not be till tomorrow morning. Okay.
Thanks again.
Pleasure. Okay. I think we are at Carl Forman.
Hello.
Hello.
So I met with Dr. Pamela Munster from UCSF, and that was via a telemedicine conference, me being in New Jersey and her being in San Francisco. And it was at the recommendation of Rick that I have a discussion with her, and we discussed multiple items. Just to discuss a few of them right now. My PSA, I've been talking here about, it's slowly rising. It's still very low. And I'm on a PARP inhibitor because of genetic testing and precision medicine. It's been working quite well for me. And more recently, the past 2 to 3 months, PSA has been slowly rising. So she has recommended that stay the course and continue on the PARP inhibitor, the olaprib. The numbers are still very low. Also, as far as with regards to PSMA scans, which I've been looking into, the my PSA right now is still too low, 0.14, to be considered for a scan from the places that I've been able to speak to. So that could be at some point on the horizon. She also mentioned very clearly that exercise is so important, and that it could very well lower my PSA back down and keep it under control. I had talked to her about the fact that I was going to the gym for several weeks, not several weeks, several days per week, up until COVID, and I haven't really been doing much of anything since March. My gym here in New Jersey is actually opening tomorrow, and I hope to be able to start back on that. She also mentioned maybe I should consider getting a Peloton for my home. So my daughter happens to have one, but and actually earlier today I was at a store that specializes in don't want to say expensive, but really good quality exercise equipment. So there's a lot out there, more on the high side, somewhere in the anywhere from $2,000 to $4,000 for a piece of equipment. So for right now, I think I hopefully will be able to get back to use my membership as opposed to buy some additional equipment at home. And the other thing too, just to quickly talk about, one of the side effects of my medication, and I think it was the olaprib, is that I was prone to blood clots. And I did have a partial blood clot I was diagnosed with. Can't even recall how long ago it was. It may have been about a year ago, and or longer. And I was put on Eliquis, a blood thinner, and I was on it for probably over a year. And then my primary care physician asked me, "Why are you still on Eliquis?" I said, "Well, nobody's told me to get off of it." And one of my oncology doctors had said I'm probably going to need to have it, be on it for the rest of my life. But he said, "Well, you know, let's see how you do by getting off of it." Okay. So this is the first that it's been reintroduced as a potential issue. And Dr. Munster recommended that I go back on to the Eliquis because I am still having some pain in the leg where I did have the blood clot, although there is no lump or bump over there that I originally detected and had a doppler that had confirmed that there was a partial blood clot there. So I just throw that out if anyone else has had experience with any kind of blood clots and using Eliquis, getting off of it, going back on it.
So the first thing that comes to my mind when you talk about the exercise is, what about MyVictory? We set you up with MyVictory, and you tried a couple of those, right? Now,
yes. I'm not as disciplined, and I know Ken is still there, and he's the master of being active, and I know other people on here are very, very active. I just need the venue of going to a gym and having all of the different equipment available to me. And as I said, starting tomorrow, I'm back in there.
I get it, and I empathize. I do empathize. I understand that, but I'm just thinking that MyVictory is a heck of a lot cheaper than Peloton, and it's the same idea, you know. And you've still got some membership. Well, I mean, we have to push MyVictory, but much better on this with AnCan. We just my bandwidth is full right now and I haven't been able to address it, but it is there and we will push it more. But this concept of being able to tie into an exercise class, I mean, you know, that's no different from going to the gym and joining an exercise class. And if you've got a spin bike at home, you can do your spin bike workout with them. I mean, you don't need to be spending huge amounts of money each month for Peloton plus the Peloton bike. You know, Mark Perloe in here in the chat window is pushing the idea of bands and dumbbells, but that only works for people that are self-motivated and willing to go down and do it. There are other people who need exercise buddies, and you know, you need to show up. One of the things that I don't know if MyVictory does, but you know, hopefully we can talk about them. To them is to create an exercise buddy. You could have a virtual exercise buddy. You know, so like you and they both go into the same MyVictory class. I mean, we can explore that. But I like the idea. I have nothing against Peloton, but we'd be happy with 10% of what you're going to spend on Peloton as a donation, and you do it through MyVictory.
Peloton is not on my radar. I looked at it. It's like the seats are just too tiny. I don't know how people comfortably sit on those things.
I should tell people what MyVictory is because we really haven't pushed it yet. We've had a couple of people try it. MyVictory is the idea, is the concept of a very inspirational cancer survivor who has essentially created virtual classes out of a cancer exercise center, and you can sign on to those virtual classes. And we have a login for you so you can try it for 90 days. Len, you tried it, right?
I did. I enjoyed it. I liked the routines, the exercise routines. I liked the people, the instructors. They were very simpatico. But for $20 a month, I wasn't sure, you know, I wanted to continue with that. I'm motivated enough to do all the things that they're doing there by myself. I really just was evaluating it for AnCan. And for those who don't have the motivation, if you can put it on your calendar and make sure that when that reminder comes up that you actually tune in, I'd say, yes, it's very worthwhile. They have yoga, they have resistance training, balance. They have a little bit of everything, all types of classes at all different levels as well.
All right, Rick. All right, Rick, send that to me. I don't know why I haven't heard about it.
Well, the reason is because we just haven't pushed it out to everybody yet, and we have to do it. And so I've got to call the guy that did it and cut a deal with him. But we will, within the next 30 days, I promise we will get it out to everybody because it is worthwhile. And I've got to talk to him about it, and we'll do it. But Mr. Forman, overall, well, I'm pleased you talked to Pam Munster because I think she's terrific. I just like her as a person. She's had her own battles with cancer, which I think is always impressive. She's a very smart doc. And I think her advice to stay the course with olaprib for the time being is good. I think she's probably a lot more, to use my fratello's word, simpatico, than the lady, what was her name at Penn?
No, Dumchek, Susan Dumchek.
Dumchek, Susan Dumchek. I think she's probably a lot more simpatico than Dumchek. I don't know. You've seen her. You've met them both. But you know what you got to do, man. So only you can do it. And we need to get that Alan Moskowitz. Call him up and exercise with him. He's in your town.
Yes, yes, he is. She also mentioned, because she's from Europe, I'm not sure what country, but she said that electric bikes are very common in Europe, and that could be a viable type of exercise equipment, getting outside. And you know, the electric bike actually helps you pedal, and there are some that have automatic transmissions. So as you're going up the hill, it just pedals harder to help you, but you still have to pedal. So
okay, so she's from a very hilly country. She's Swiss. Okay, so she knows a lot about hills. And I know a fair amount about electric bikes because I ride a mountain bike, and I have very good friends, the people who are coming in right after this meeting, who have electric mountain bikes, and he's in the bike business, and he lends me his electric mountain bike. It's when I ride with them sometimes. So I rode Saturday, I rode their electric mountain bike, and you get a very, very good workout on an electric mountain bike, but it gives you the assist when you need it. You can regulate the assist. So you can be going up a steep hill and pedaling very easy if you want that much assist. If you don't, you back it off. I would talk to Jerry Deans about an electric mountain bike this week, and I talked to one of my blood cancer guys about an electric mountain bike. You can buy one anywhere from about $500 to about $1,500. The ones that Peter has are a lot fancier, but I will send you Radwheel, RADWHEEL, Radwheel is the, I think it's radwheel.com. And Peter can get those bikes. I think he can get them at a good price. Radwheel.com, try it. I may be wrong. But yeah, I mean, I do think that it is a good alternative, Carl, but you still got to get your ass onto that bike.
right, and of course here in the Northeast, you do have winter months where there's snow and whatever else and my son-in-law said, "Oh, you're probably better off with something like a Peloton because you can do that 12 months a year." But I really, I'm not too thrilled about making a commitment on Peloton.
Carl, where do you live?
In Monroe Township, New Jersey, just outside of Princeton.
Okay, I'm in New Hampshire.
All right, guys, keep checking that chat window. There's good stuff in there. Dr. Perloe has been putting in all kinds of good information for everybody, so keep watching. I'm going to go to Gao Shan. Gao Shan, you mentioned that you have got a scan set up. Just remind the guys about your situation.
Okay, I had my prostate removed in 2013. My PSA at the time of the surgery after 3 months was 0.02. It stayed quite low for a long time, but in the last 2 years, it started climbing. I did use flutamide over a period of time of 1 year, but stopped using it in November of last year. And of course, the flutamide would normally reduce my PSA by about half, 40 to 50%. At the time, right before I stopped using flutamide, it was around 1.19, 1.2. My next scan, my next PSA test that was done in January 21st of this year had gone up to 2.6. Or 2.66, and then in June of this year, after I was stuck due to COVID and unable to fly back to my home in Taiwan, I contacted BCCA in Vancouver, BC, met a doctor there, and also had another PSA test, and it actually dropped a bit, but probably just the difference of one testing facility to another from 2.66 to 2.6. And then in end of August, I had it checked again, and it was 2.75. So it rose up again higher than it had been in the past. I've been talking to UCLA to get an appointment. I had an appointment scheduled with them, but I did a two-pronged process of checking with hospitals in Taiwan and also with UCLA. One, to make sure Taiwan had the GA68 PSMA scan, which they did. I organized an appointment and a scan around September 21st of this year. UCLA could give me a scan on the 10th or 12th of September, but the problem is my time in Canada was running out and I had to go back to Taiwan. So I proceeded now to be back in Taiwan, and I have, as I say, the appointment on September 21st, really to see where my issues are. Is it still in the pelvic area, or has it gone some other places? While I was in Vancouver, I also visited and made 2 appointments with a naturopath oncologist and got some recommendations from her. Of course, exercise, but I exercise all the time, 4 or 5 days a week. I ride my bike for an hour to 2 hours every day, use the rubber band things for exercise at home. I think I relatively eat well, but she did a whole bunch of different blood tests to check for inflammation and iron and a whole bunch of other things, which have not come back yet, and then recommended some other stuff. So I'm now at a point where I need to do the scan and see where I'm at. Of course, once you know where you're at, you can start making decisions of what your treatment will be.
Well, I mean, first of all, I think we're all really happy that we encouraged you to get that PSMA scan and you're set up to do it. I'm curious, is it part of a trial in Taiwan, or will you be paying for it, or?
It's a trial, but I'll be paying some money similar to what UCLA is charging. It's under $3,000 or around that price point.
Okay. Well, what time of day is it now in Taiwan, Gao Shan?
It's Monday morning or Monday afternoon now. No, Monday morning, 9:41 in the morning.
Okay, so there's no,
excuse me, Tuesday. What am I saying?
Tuesday. So let me just say there's no excuse for you not to join us and give us your report.
Yes, absolutely.
Okay, and we expect to hear from you from Taiwan, telling us about your experience, and then let's talk to you about how we can guide you in terms of where you go next.
Right. I did, the doctor at BCCA did reach out to me before I left and said that as a free service he would do on his own time to review the scan and recommend anything. And then I also reached out to somebody at UCLA that also would be able to give me some analysis, but I haven't proceeded on either of those. Once I get the results and know where I'm at, I'll get back and report to you, and then you can give me some additional advice moving forward with the doctor. I also sent an email to the doctor this morning that I'm working with at the hospital for the PSMA scan and asked them with regards to the thing that was mentioned earlier about a GU medical oncologist doctor, if that actually exists at their hospital. Unfortunately, from what I've been told, that prostate cancer is not that high of an incident rate in most Asians.
No, know about that. I mean, I've heard that too, but there's plenty of studies that
Oh,
are
I don't have the
going on.
data. I was just told that by a couple of people in the medical field, one being a urologist, but that's just what I was told. So,
You know, I funnily enough, it was mentioned in something I attended last week, and I wanted to go look at it more carefully, and I haven't had time to follow up. But I don't think that that's necessarily true. And there's a lot of good work that's being done in Japan and in China in terms of
right.
In terms of research. So
Right.
anyway, look, thank you so much for coming back. We're delighted to hear your voice again, and we're delighted you're making progress, and stay in touch with us.
I have two other things, two short things I want to say. When I met with a naturopathic oncologist in Vancouver, BC, she recommended, besides a couple of vitamins, or supplements, which I already take to reduce inflammation and some other things, she also mentioned that there's a fair amount of research, at least what she quoted, about two other naturopathic therapies. One was a pill called low-dose naltrexone. And she gave me a link to look it up. And then she also mentioned that there is, for diabetes, metformin. She says that it's been shown that people with prostate cancer can also benefit with that. But to me, that was odd, since it's for diabetes and dealing with your pancreas and stuff. And I wondered if anybody had heard of this recommendation before or not.
So we can definitely address the metformin, and there's a lot of history and even some recent trials on metformin, and the jury is out, but it does, provided you take relatively low doses, it's probably, if it were me and I had metastatic disease, I would be taking it. It helps to regulate the glucose and
Right.
To some level reduce the glucose, and we know glucose is not good. I'll let Len say more in a minute. The other drug, what was the other supplement she discussed?
Low dose naltrexone.
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 It's an opioid. It's an opioid inhibitor. I've never seen that mentioned regarding this. The issue on the metformin that's interesting is that it's beneficial in terms of the sugar, but it also deals with an enzyme called mTOR that protects the chromosomes. So
Yes,
there's a lot of information, but it's not ready for prime time yet. As you said, it's all trials.
Right, she mentioned exactly that when she gave me the data to look into. Now, she's saying 500 milligrams. Is that considered a low dose twice a day?
Well, you may want to try, if you try it, start off with 500 once a day until your system gets used to it, as Jake will
what I was planning to do was to cut the pills in half, or do 250 in the morning, 250 at night. Or you just take one a day in the morning or whatever.
Take it with the meal and not on. I've got about 60 or 70% of my patients on metformin.
She told me always with a meal. Don't take it on an empty stomach.
And for a week to 10 days, take one tablet a day with the meal. And then in the second week, once your stomach is adjusted to it, you will do a lot better, and then you can increase it. If you're cheating and eating a lot of processed carbs, you'll have upset stomach and loose stools. A lot of people will have that for 6 to 8 weeks, and then it goes away.
Yeah, I don't eat much of that. Mostly vegetables for many years, and fish, and occasionally chicken, but no chicken skin.
Rice would be the problem there.
Yeah, I don't eat rice.
Okay, well,
I don't eat rice and very little pasta, maybe once a month.
right. So Jake will testify personally to Dr. Mark's advice. And now we know that he must have been eating a lot of processed food there. Mr. Hannum, were you eating a lot of processed food?
Most likely, yes. I don't keep track of my diet like I should, but yeah, I probably was.
And then we cut you back to 500 and you've been good ever since, right?
Pretty much, yeah.
All right, so Len, do you want to add anything on either of these two drugs?
Well, with regard to metformin, to my knowledge, it has shown benefit in prostate cancer patients who have metabolic syndrome or are diabetic or possibly pre-diabetic. I'm not sure that it's been ever been shown to be helpful to prostate cancer patients without any of those syndromes.
Okay.
In clinical trials. Are you in any one of those categories? It doesn't sound like you are.
No, not at all.
Yeah.
Well, Rick, if you remember several years ago, we had a doctor on here. I don't remember his name, but he talked about SAM, statin, aspirin, and metformin as a protocol.
Right. Dr. Moyad.
Yes, that's the one. And I've been doing that, and I don't know if it's been helping me or not, but I don't think it's been hurting for sure.
Okay.
I mean, I'll second what Lynn said. When I first was diagnosed and put on systemic therapy, I looked up metformin because it was there, and I couldn't find any really clinical trial evidence that outside of what Lynn said, mainly for metabolic issues, that it had any effect at all on prostate cancer.
Well,
So,
I've got some.
I do have a link that I can send you where some good work has been done on metformin. And for years and years, Snuffy Myers was a big metformin fan and pushed it. And pretty much everybody who comes out of PCRI, except maybe Peter. I don't think Peter's on metformin. Are you on metformin, Peter? How did you miss that one with Jeff Turner?
I've been doing it for over 3 years.
Oh, excuse me. So everybody who comes out of PCRI is on metformin. And if it were me, I'd be taking it. That, as I said that before. So that's just my opinion. I would be taking it. Yes, I know where the evidence is, but we have some other things. I remember Dr. Steve, God rest his soul, did a bunch of research on it. I should add for Mark Perloe's benefit that that my buddy Steve, our buddy Steve, was a OBGYN practicing at Kaiser, but was also very much involved in medical records for Kaiser. And we lost him to prostate cancer. He got diagnosed with a PSA of about 1,000, and he lasted about 3 years. It's a long story. We'd be happy to share it with you another time. But Steve did look at it quite extensively and decided to take it. So, all right, we got to keep moving. We've got 10 minutes.
Oh, just one last question.
No last thing. Sorry,
Okay,
Gal.
you're good. Okay, thank you.
I've got to move on.
Go ahead.
We've got to visit with Ken and Herb and Russ. So, Ken, give us an update.
All right. Well, first, I can reiterate that MD Anderson in Houston does recommend 1,000 milligrams of metformin, once in the morning 500 and once in the afternoon and 500, both with meals. So I would recommend it. My comments today are in relationship to radiation. You know, I've had 5 rounds of docetaxel. It's a docetaxel re-challenge. I had the first 6 rounds in 2016. So, and I was pretty happy with the 4th week or 3rd week on docetaxel. My PSA dropped down by about 20 points. Recently, I've developed these small blisters on my hands. So I don't know. I'm pretty sure it's related to docetaxel. They're painful, which is the first time ever that I felt like cancer-related pain. So that's about it.
So
I had that. It's called hand-foot syndrome, and due to docetaxel. And I think that was the thing that my oncologist told me it's time to stop. I had it both on my hand and on my feet, and my skin was peeling off. And so it's not uncommon.
No, I did some research and I did see that there's a percentage of guys that get these small, like, burns, or they really look like a burn, like you had stuck a torch to your hand and burned it. They're real deep blisters. Right now I only have 2. I'm scheduled to have round 6 of docetaxel on Friday, and I'm going to continue. But I must admit, if it goes to my feet and I can't walk, it's a done deal. I'm not doing it anymore. So,
well, what does Paul Korn have to say?
I didn't send it to him. I was going to ask my local med-onc here but I did a lot of research in regards to, blisters, and it's not common, but it's out there. It happens.
Well, I mean, I definitely, this is the sort of stuff, this is why you've got a great medical oncologist. Talk to him because he's seen it before and he may have some suggestions as to what to do. I mean, maybe as in Herb's case, you stop, but maybe there's some other things. And so you got to let him know. So.
Well, I can do that. Yeah, I can do that. I can send him a note saying, "Hey, I'm getting blisters. What do I do?" I know what you do part is. They do like some kind of a cream to alleviate the pain. It doesn't. I mean, the condition is caused by chemo. Either you stop chemo and it goes away, because it does go away, or you don't.
I'm sure it does.
It does go away.
I know it does.
It does go away, but Ken, let me go back to an issue we've talked about before. Do you have a palliative care doc, a symptom management doc on your team?
And I've looked and looked and looked. I do not have one. No, Rick.
Okay, so you've got to get a symptom management. I mean, they're there at MD Anderson, and ask to be set up, because this is exactly where a symptom management doc is useful. And it's great doing your own research on the net, but the reason we recommend symptom management docs is because you get symptoms from chemo and other drugs that you're taking, and these are the docs that know the best way to treat them. And they're the ones that are going to say, maybe you want to ease up and maybe a lower dose. I don't know, but those docs know the answers.
All right, I'll take your advice as always. I'll give Paul a call and have him put me in touch. I know this is your second attempt to get me to do it, but I'll do it this time.
Okay, I mean, anybody else want to comment on that?
Yeah, I've got a quick comment. We never talk about this on our call. And I'm not trying to draw a comparison, but when you're on chemo with prostate cancer, it's really wise to stay out of the sun, and watch exposure to the sun, because we're really susceptible to our skin cancer. So just be careful, guys. I know I was living in Hawaii. I've got to really watch it.
No, I did read that, Peter, and I believe it's true. I don't know if that's why I got the blisters, but I do believe staying out of the sun is important.
Okay. Anyone else on this before we move along? All right. So please try and get a symptom management doc onto your team. And that goes for everybody who's in advanced treatment. Herb, you had an update for us.
Right, so the update is latest PSA was stable. It's 2.2, so that's good. It means that at least right now the disease is not progressing. So that made me feel good. And the other thing that made me feel good is that I was a former marathon runner, and the weather turned here to the point where I could get out and run again. And so I actually have had a couple of, I wouldn't call it running, but it was out there exercising, getting me up to sweat. And so that sort of raised my, sort of gave me some positive feelings, because otherwise, and then Carl, I have the cheapest crappy stationary bicycle in the basement. It's something I inherited from my mother. But I get on it every morning for half an hour and get my blood pressure up and sweat like hell. And it doesn't cost a whole lot of money. And so I would say the exercise has been good. But I have to say, I'm looking forward to at least until the weather turns cold to get out and do some more running. So that's it. Oh, and one last issue. I'm still, sort of with radiation, I've also tried to look for data that compare proton with ionizing radiation in terms of both success and side effects. And I cannot find anything other than sort of retrospective analysis. So if anybody has any information, I'd appreciate it.
So a few quick things here. Number one, I am also an ex-marathon runner, so I empathize with you 1,000%, and I know exactly what you mean when some people might not call it running, but I know what you were doing, and I'm glad it makes you feel better. How many marathons have you run, Mr. Geller?
I did 5.
Okay, well, I think I did 9, but I can't remember anymore. But I wrecked my ankle in a bike accident, and I had to, and so
my best was 3:15.
Good.
So.
Okay, I'm impressed. I went to rowing, and the reason I was late on the call is I just got back from the lake, and I have some blisters because I haven't rowed for 3 weeks. But rowing is a great alternative. Secondly, PBRT. There is a trial going on. What I recommend you do, have you been to Alan Adele's blog?
No, yes, I have.
Okay, have you looked on Alan Adele's blog for references? Because there are trials going on. He'll have them referenced in there.
Right, there are trials going on, but there's nothing published, no published results.
No, they haven't reported, no. Because it's such a long time, because the time frame is so long. That's the problem.
Right. And I have to tell you that my physicians at NIH are really rigorous in terms of wanting to see clinical data from randomized trials to support what they will do.
Well, I have something. I'll try and make a note. Herb Geller, I've got something I can send you. It's old, but it does look at proton versus radiation, and it suggests that one has one type of side effect and another has a different type of side effect. And I'll send it to you. PBRT. This will be again tomorrow versus IMRT. This will be.
Thank you.
I'll try and get to that tomorrow. And anybody else want to say anything to Herb about exercising or about the fact that we are delighted that his PSA is stable, or about PBRT versus IMRT?
Herb, is the consideration of proton beam for spot radiation?
Yes, well, for prostate, we're basically focused on the prostate.
But you still have your prostate. You had no radiation.
I never had radiation. This is to sort of try to do the best to limit the prostate as the primary.
Okay.
And
So-
I like to comment that Herb could exercise on his mom's bike and get enough exercise to satisfy him. So Carl, it doesn't cost a mint to get exercise. You can go buy a secondhand bicycle out of a secondhand store for $20 and you'll get enough exercise. You just got to get on it.
But I also understand that when you do exercise on a bicycle, it may very well temporarily increase your PSA if you're doing it very close to when you're having your next blood work.
Exactly. So I had my blood work last Friday, and I did not bike on either Thursday or Friday.
Right, hold on a minute, guys. Herb, you're right. Carl, you're wrong. You don't have a prostate.
Does that matter?
It's absolutely true, Carl. Your position is bogus. Buy a $20 bike, put it in the basement, and get your butt on it.
I have no business.
Go to, I'm serious. You go to Craigslist, look on Craigslist. Everybody wants to get rid of the bikes they're not using anymore.
I do have a bike for outdoor use. It's called a comfort bike. It has a relatively large seat, and I use it on a rare occasion.
Okay, well, we like giving Carl grief about the exercise, but he knows, he's heard the message today. He knows what he's got to do. And Herb, I'm delighted about what we're hearing, and I'll try and give you some more information on the PBRT versus the IMRT issue. Lastly, Mr. Smith, last but not least.
No, I'm the least.
Not true.
So simple. This is a question is I'm trying to get, my last Lupron shot was 5 weeks ago, but I still have muscle pain and, Lupron effects. How long does it take to get, it out of your system, Lupron and Casodex?
You had the 3-month shot?
The last one was just a 1-month shot.
Yeah, it'll take more than 5 weeks to wash out.
Do you think?
I think so.
By definition, if you get a 1-month shot, it is 100% effective at 1 month. It's going to last until it feathers down from that, and it's not in any hurry to leave.
And when should I stop the Casodex?
Hold on a minute before the next question. Dr. Mark, please.
So again, you may get the Lupron cleared from your system, but to get the testicles responding to hormones and starting to make some testosterone on their own can be quite some time. In women, we're seeing that they can restore a period. It can be 2 to 3 months after the last shot of 1-month shot of Lupron. So yeah, I agree. It can be an extra month or two after that last shot.
I'm having tough effects on my lower leg muscles and my shoulders. Now I just moved into a new house and work, but I've kind of I feel I hit a new low after being, feeling better. So I'm sure it's just a little lag.
So let me give you the rough rule of thumb, which you're not going to like very much when you hear it, which is that the old heuristic rule was that it takes twice the time that you're on the drug for it to wash out your system. So if you did 6 months, it's going to take you 12 months before you're back to normal.
Yeah.
Now, everybody's different. It depends on what your levels were before. It depends hugely on your age. So the younger you are, the quicker it is. I can tell you in my own case, I was on it for 2.5 years, and I did not show any testosterone for 6 months after I stopped. And then 6 months it started to come back. And it was probably, in my case, I was probably back up within a year to 18 months. So it wasn't 5 years for me. But I think that 6 months, that realistically you should be thinking at least 6 months to between 6 months and a year, realistically. When are you getting tested next? When are you getting your testosterone and your PSA tested next?
6 weeks.
6 weeks, okay. Unfortunately, there is very, very little literature on how PSA returns. There's a lot of literature on how quickly testosterone returns. So there's loads and loads of studies on how quickly testosterone comes back, but there's nothing about PSA. And I think you've heard me tell you that the best explanation I got on the PSA return was from Dr. Frank at MD Anderson, who explained to me that it's quite likely that the PSA can go up before it goes down. So don't get scared by that. But that was for somebody who had radiation therapy and hormone therapy from the beginning. That wasn't the salvage situation or the adjuvant situation that you're in. But don't freak out over your PSA just yet. There's a lot of explanation.
I'm happy with my PSA. It's just the muscle reaction and the fatigue.
I think I hate to say it, you just have to be patient. Keep exercising. You got to keep the exercise going. Keep
I do.
I know you do, and you're that.
Football season's coming up. I'm not sure I can do varsity this year, though.
Does CoQ10 help in this situation? I know it does with statin, but does anybody have any experience with a CoQ10 will cut down some of those cramps?
Statin. I don't handle statins. It makes me crippled.
Okay. I don't know to what extent CoQ10 will help you. I know that Dennis Correa swears by his cramp medicine, which I always forget. What's your cramp medicine, Dennis, that you always recommend? You're muted, sir. Unmute. There you go.
What is it?
We still can't hear you.
Thorough works. It's a magnesium supplement for cramping.
I don't have much cramps. I just have more muscle fatigue. That it's hard to walk, and we just moved into a new house, and I've got to do a lot of yard work and get a new yard and got to move the sprinklers around and just I call myself peg leg because I can't really move the knees. But I have arthritis in the knees that is being affected by something.
Well, my med-onc would say you're just getting older.
Yeah. Oh, I'm only 59.
Oh, well, so am I.
Yeah, I played softball up to last year.
All right, guys. Look, we ran over and we didn't get everybody's questions answered, but we did a fair job. So next week, remember, our Tuesday meeting is next week. I know it's the third week, but we had to switch it because otherwise we would have had meetings on successive nights. So our Tuesday meeting will be next week. We'll be reminding you, and we'll see you all then. Oh, and don't forget the PCRI conference. That's it.
Love you guys.
Ciao.
Have a
Take
good
care.
week. Take care. Thank you.
Good night. Good night.
Okay, good night. Thank you.